we can see that it's a huge economic impact of disasters, natural disasters such as earthquakes and storms, affecting primarily the poor people in the world. If you look at the left side, you can see that the economic losses from natural disasters are primarily due to storms, and this has become more prominent as we come to more recent decades, whereas the loss of life is more due to earthquakes. And that's because there's obviously less of a warnings with an earthquake than with cyclones, for example. But in addition to the natural disasters, we have these what we call unnatural disasters, terrorist events and industrial disasters. And as we can see here, if you look on the left, in the low-income countries, natural disasters are a major source of injury. Road traffic accidents are another source of injury across the spectrum of the world. If we look at the economic effects of injury, the loss in GDP of not treating these is huge. It's trillions of dollars a year and just going to get greater as we move forward. Another big area that surgery is very important for is neoplasms. And so there's really an incentive to bring surgery to the fore in the world scene now. We've gone past the point of treating infections and clean water, mosquito nets, and now we're turning to the next phase of healthcare delivery. And that, many of you are probably familiar with the Lancet report came out on global surgery 2030, and it really will boost the world economy as well as boosting the healthcare around the world by investing in surgical resources now. And this has hit the lay press in the U.S. and elsewhere, and you see people like the head of the World Bank also acknowledging this is the next step in healthcare globally. Well, the earthquake in Haiti in 2010, it was estimated that each day following this, 20,000 people died because there weren't basic surgical services available, from fractures, blunt trauma, head injuries, things that could have been treated, and these would have been functional individuals who died. A huge number, probably 100,000 people died who could have been saved. Interestingly, the only group that was there with any surgical resources was the Icelandic search and rescue team. Apparently they're ready to go on a moment's notice, hop in a plane, and they got to Haiti within 24 hours. The problem there was it's too little and too late to help injured patients. And this is a bureaucracy that they had to deal with in Haiti. You can see why things didn't happen for quite a long time. If you look at the UN, this is their path or their chart for distributing people for response to disasters. It's a huge bureaucracy. The World Health Organization, if you look at the timeline on the right, it's about a week before anybody's actually on the ground and helping people in a disaster area. And here's another symbol of the very complicated bureaucratic response to disasters worldwide now. So why has this been so ineffective? Well, disasters are pretty rare. They don't respect national boundaries. And there's this huge bureaucracy we've mentioned. And again, there's nobody ready to go immediately, except in some of the militaries have disaster response teams, but not in the civilian sector. And so we've looked at this as a humanitarian response, NGOs and the groups like the UN, WHO, but not any national organizations. But there's also sort of a silver lining to disasters because it is humanitarian. It brings people together who might otherwise not cooperate. So how do we improve the response to disasters? In our way of thinking, it looks like if we learn from the trauma and stroke centers that came about 30 or 40 years ago in most of the developed countries, where that's integrated completely into the ongoing healthcare system, we can do the same thing for disasters. Everything from medical education, certification, delivery of care, and rehabilitation would be integrated for disasters, as well as strokes and trauma. And you can see here a statistic that if you are taken, say in a road traffic accident, you go to a general hospital as opposed to a trauma center, you have a 30% greater chance of dying in the first 2 days. Our colleagues in Finland, as far as stroke, same sort of thing. If you go to a general hospital instead of a stroke center, you're more than 50% more likely to die, and you're much less likely to end up going at home a year after your stroke. So there's plenty of evidence that this sort of integrated system system it works great for trauma and strokes, and it can work just as well for disasters. So you really need to integrate it, as we see here. These are some of the points that we need to raise. You've got to be on site within 24 hours to be of benefit. We're going to need helicopters to transport all the personnel and equipment that's needed. And so we're hoping to develop sites around the world, and we'll have 2 sites that we're working on presently. And you can see here that the system has to be fully integrated into the ongoing healthcare system, and as well, we need to have this ideally in an underserved region, so it will benefit the healthcare not just during disasters but at other times, and it has to be in a place where the government is stable enough to have an ongoing system survive and thrive. And finally, this collaboration between developed countries and underdeveloped, and you actually have this pretty much in India itself. You've got very developed centers and then underdeveloped regions, and they could work together. So some of the benefits is of the camaraderie of working across different areas in a country and between developed and developing countries. The benefits to the development of research centers. There's would be a very amazing research platform to have these centers throughout the world where you could be conducting research on various aspects of medicine. It addresses public health issues, and most of the NGOs and medical groups like the Neurosurgical Society in India have goals of developing better health care within their country and across borders. And these are some of the organizations we've been working with, everywhere from, if you look down there, Think First and Pansebem in Brazil, about trauma education to avoid injuries to begin with. And interesting, in Brazil, they've taken this to the point where 30% of these students in elementary schools are actually go through training in injury prevention. We're not doing that sort of thing anywhere near as successfully in the US. And then also the various organizations that deal with disaster response. We're interested in coordinating these people, not setting up a new organization. And so what do you need to do? You need to bring all these things in when at a disaster site. You may not even have the personnel because they may be injured in a disaster as well. And as we've seen in this conference, telemedicine is crucial. So here you can transport a portable operating room. There are groups in the US, and most of the university medical centers have disaster response teams, emergency physicians, but they're not ready to go in a moment's notice. It takes them a few days to get cross coverage and actually get to a disaster site. There are equipment available that's very helpful. You can see here a portable CT scanner, weighs 400 kilograms, and it runs off a car battery. So you're going to find any disaster site anywhere around the world, you're going to have a car battery. So powering these sort of equipment is not that difficult. Here it is in a Russian ambulance. And they've also developing, now that Samsung has taken this over, a portable, it's meant as a portable imaging center, but you can imagine this is actually a CT, intraoperative CT, used in trauma, or used in disasters, but in non-disaster times, it's an operating room. And so the trauma surgeon's a general surgeon, the neurosurgeon is doing his neurosurgical work in an operating room that's portable. And the other technology that's available now, this is in Canada, these mobile cameras that are mounted in the top. This is a clinic in very northern Quebec. They have small clinics for the native tribes up there. And there's a trauma surgeon there in the upper right. She's guiding these cameras and acting as a surgical assistant. And this is a schematic of that setup. And interestingly, that same group has developed a portable camera system that can be controlled by, again, a trauma surgeon. So if you go to a disaster site or even just an individual trauma, you can follow that patient both audio and visual, as well as all their vital signs constantly from the time that they're actually met by the first responders. This planning really does help, and this is an example from here in India. Those 3 cyclones that I show there, great loss of life in Myanmar and also quite thousands in the Philippines, but very little in Odisha because of it's a basic telemedicine system. It was very effective in evacuating over 1 million people and saving, no doubt, several thousand lives. And that's thanks to the people here in the audience. Now we turn to some of the newer technology that's coming on for disasters. NASA's involved in some of this robotic development, and you can see here it's really a worldwide effort. There's efforts in Italy, in Germany, South Korea, the US, and no doubt here in India too, developing robots and drones for disaster response, both fixed wing and rotary, and they can have very sophisticated sensors. And as we see in this next slide, you could be sensing, on the bottom it shows sensing endangered species under a canopy of foliage in jungles. This could equally well be people who are underneath rubble who are still alive because of the thermal characteristics, and drones can actually detect this. In the upper right you see a drone that carries a portable defibrillator to a patient who might, or an individual might have a heart attack, and it has vocal guidance, so the person, a first responder who doesn't know how to use it will be guided on how to defibrillate a patient. This is an interesting drone that's on a tether and could, for hours or days, survey the same site. And so you can actually see the disaster response, and if there's earthquakes and additional tremors, they can follow how that changes over time. If you're interested in this, CRASAR, headed by Robin Murphy, is a great resource for this. They will send you robots and drones on a moment's notice. And this is basically the system. You have these surveillance drones are constantly providing information to this triage person who's wearing smart glasses, and they're guiding the first responders to the most appropriate places to detect people in rubble and whatever types of response are needed. It's an ongoing, constant event. And as you see here, this Ocular Go is coming out next year for close to $200 US. No doubt somebody here in India is developing the same sort of thing for probably a tenth that cost. So this is high technology, but it's not high expense. And this was used in Nepal. They had crowdsourcing to identify the various buildings and other structures, as well as roadways, et cetera, in a disaster site to help the responders. And in Russia, they used social media and disaster response. These were forest fires, and the social media was constantly conveying to the firefighters where to go next, who to evacuate, et cetera. And this has hit the lay press in the US of how these drones could change this whole game of disaster response. Instead of getting there a week later, you're actually on site in hours, and really that's the only way we're going to save people who are injured. If your drones are actually being used now by the UN response team, and if you're interested, on the left-hand side is a book that Robin Murphy published a few years ago. I just want to mention in closing this National Center for Disaster Medicine and Public Health that started in the US several years ago to bring together the government agencies and the civilian agencies that could deal with disasters. And as part of that, the military in the US, which is really the only group with major response for disasters, is now uniting with the trauma centers, many of which are affiliated with universities, to work together. And this is exactly what we're trying to do on an international scene. The US is starting to do on the national scene. And this is just a schematic of how that is planned out. And this is what our working situation is now. One center would be in northern Chile, which is rather centrally located for most of Latin America, and the other, thanks to Tariq Khan, is in Peshawar. If you're interested in reading a little bit about this, we have a paper that came out a couple of years ago, and we're doing another paper, an update on this, will be coming out in a few months. And just to tie this in with NASA and healthcare, Ruchi Pandya was a high school student who worked with, not on the projects that I'm working on directly, but with our nanotechnology group at NASA Ames. And she actually won one of the White House Science Awards 2 years ago as a high school student. And she has a YouTube video with President Obama reviewing her project, which is in healthcare diagnostics, paper-based, nano-sensitive. This was for looking at troponin levels in myocardial infarction. If anybody's interested, as you can see there, 3 of the 4 people working on this project are from India originally. So you've got lots of representation at NASA Nanotechnology. With that, I'll conclude. Thank you.